For this lecture, we're going to begin looking at our peripheral arterial disorders, specifically issues with circulation to the lower extremities, aneurysms, and acute arterial disorders. When we talk about acute arterial disorders, we're only going to discuss Raynaud's and thromboangiitis obliterans. So in previous lectures, we've talked about the fact that if you have athero or arterial sclerosis in one place, that you are more than likely to have it every place. And having that decreased perfusion will cause damage long-term, especially left untreated, to your lower extremities in this particular case, since we are talking about PAD. Some of the things that you look for, some of the teaching that you can think about, or questions that we can ask are if the client is experiencing any kind of pain when they walk, do they have any discoloration in their feet or toes, any complaints of leg numbness and tingling, so paresthesia, heaviness, weakness, any changes in what their feet look like, especially in the growth of their toenails, any ulcers that aren't healing correctly, and any temperature extremes in their lower extremities. In the picture, we see that this client on the left has what is called dependent rubor. So the client has probably had their legs elevated a little bit. We're going to talk about elevation a little more, and then once they put their feet down, blood kind of rushed, and it kind of overexcited that extremity that was not perfusing, and we have those extreme color changes. It can also be caused by occlusions or extreme decreases in circulation. What you'll notice here is what we talked about. There are some changes in the toenails for both of these clients. You have thin, brittle toenails. You see the skin is shiny. It's usually going to be described as taut, hairless. So again, when we're looking at these lower extremities, since the feet are most distal, that's probably the first place that you're going to start. So we can have issues that are either acute or ischemic. You have color changes, red, white, or blue. We know that PAD just is a process from arterial and atherosclerosis, and it's going to produce a decrease in perfusion to the lower extremities. Risk factors are pretty much the same. Nothing really changes from any of the other cardiac disorders, cigarette smoking being a big one, cholesterol, lipids, fat, diet, lack of exercise, hypertension, other underlying comorbidities, diabetes, COPD, obesity, genetics can also play a role. And in this image, you have sort of this little checklist where we can go through and try to kind of evaluate the client for where they're at. And it's just the same questions that we've already talked about, but it's a good tool to help you recognize, does your client experiencing any complications from PAD? The big one, again, is just if they're having pain that does not go away, it's no longer just PAD, it's acute arterial occlusion, and that's going to be more urgent for us to probably send them to the ED or have them looked at more emergently, because that pain should not stay or should not wake you up, just like we talked about with chronic stable angina. So the classic sign and symptom of PAD is intermittent claudication. Intermittent claudication does come in stages. So obviously stage 1 here is we have this reduced pulse. Stage 2, you have signs and symptoms of intermittent claudication. Again, that's just pain when you're doing activity. So ischemic muscle pain or pain that is precipitated by constant levels of exercise. It should go away within 10 minutes or less with rest. So again, we're kind of equating that with chronic stable angina. You still want to make sure that you're asking them OPQRST. they're going to come in and they're saying this, hey, this leg pain, it's waking me up at night. I have it whenever I walk. It's all the time. It's constant. It is no longer just something that we can say that, okay, well, medications, diet, exercise. They're probably having acute arterial occlusion. And since it's acute, you know it needs immediate intervention. And then if they do delay getting seen, they can end up with ulcerations. And again, especially if they're already a diabetic, you know that they are at increased risk for sores because we're not getting enough oxygen and nutrients to our lower extremities. It is very hard to differentiate a sore from diabetes and a sore from PAD. You need to understand that if you're talking about intermittent claudication, it is reproducible because once they stop and rest, we said that it is precipitated by a constant level of exercise. So we know that one of the diagnostic tests that we're going to think about is an exercise stress test. And kind of the expected findings, we've already been through them, right? Again, the priority one is any pain that does not go away, that is not resolved within 10 minutes, needs to be re-looked at, reassessed, whatever you need to do so that you understand that we're not cutting off circulation because you're going to make them lose that foot. We talked about the diminished or absent pedal pulses, popliteal, femoral pulses, thin skin, taut skin. Obviously, they're going to have changes in their cap refill. We talked about loss of hair. We talked about temperature extremes. So we just remember it by the 5 Ps. So you have pain. Again, it should go away. It's reproducible. You have a pulse. If you don't have a pulse, you need to get a Doppler. If you don't have the dorsalis medius or the posterior tibia, you need to move up to the popliteal and then to the femoral. Color changes, red, white, or blue. You're going to see lots of pallor, is what they're saying here, because of that decrease in perfusion. Paresthesia, again, is just our fancy way of saying numbness and tingling, obviously because that lack of perfusion is affecting your nervous system. And then if you get to the final P, we've done a real injustice to our client. It's paralysis. That client can't move, can't really do a whole lot with that lower extremity. So just your 5 Ps as a helpful mnemonic. So much like our expected findings, our complications are pretty much the same. You know, if we don't have a palpable pulse, we need to do Dopplers, or we need to move up to find that pulse, or we're going to have to send them down for some sort of procedure. We see ulcers that develop. It can possibly lead to gangrene because of that decreased circulation. And we've talked about the fact that if you don't have, or if your pain does not go away, then you know you progress beyond just, oh, it's a little occluded, to acute arterial occlusion. So things that we could kind of expect, we talked about an exercise stress test. An MRI is kind of but I don't expect a basic nurse to do an ABI, an ankle brachial index, but I would expect that that is something that a NP or a PA or a doctor could want done. So what we're doing is we're comparing the pressures in the lower extremities, here the ankle pressure, to the brachial pressure. And then we're going to compare these, and I'm not going to have you do that because that's not basic nursing. But if you get that value back and it's less than 1, so you see here the normal is 0.9 to 1.3. So if it's less than 1 in either leg, that's diagnostic for some form of peripheral arterial disease. The most common, what I would expect you to ask for, are duplex Doppler studies, blood flow studies. We want to look at blood flow. We want to make sure we can see it moving, where those impediments are. which part of the leg is not getting perfused. All the good stuff that you know. Client-centered care, just encourage exercise. We've talked about we want it at least 30 minutes a day, 60 minutes a day if possible. We want to do things that promote vasodilation, so things can be positioning. We're going to tell them to make sure that when we are elevating the legs, because they still will feel like they want to, that we do not raise your legs above the level of the heart. We want warm socks because, again, you have temperature changes. Loose clothes because you don't want to increase constriction and avoid cold weather. The problem with PAD is that it doesn't stand by itself. It's not out there on an island. Usually, if you have an arterial disorder, you also have the venous disorder. So that means you can have both the arterial signs and symptoms with the venous signs and symptoms. And we see this all the time in the rooms when we walk in, and our clients have both hairless legs and brittle toenails with swelling and deposits of hemi, which we'll talk about when we talk about venous disorders. You're going to teach them to avoid crossing their legs. Again, no restrictive garments, so TED hose or compression stockings, however you see it on your tests or NCLEX, are not indicated. And we do want to teach them, it's okay to elevate those legs, just not above the level of the heart. Drug therapy is kind of pretty much the same. We would expect an antiplatelet medication, so aspirin, clopidogrel, fluids if it's an issue because our blood is viscous, if we've had edema or swelling and that fluid has shifted from the vascular to the interstitial spaces. Cilostazol is going to help promote vasodilation, help those red blood cells move like they're supposed to the lower extremities. ACE inhibitors are given for the same reason that we give them for heart failure. They're going to prevent remodeling. Instead of remodeling of the heart, now it's remodeling of the vasculature. Hopefully it will improve your peripheral blood flow, increase your ankle brachial index, and improve how far that they can walk. And then, of course, if it's because of cholesterol, whatever, we can put them on a statin medication. There is a drug alert here that you should not, or you should be wary of using clopidogrel and omeprazole. The antiplatelet effects of clopidogrel is going to be reduced, which is going to increase the risk of MI and stroke. And again, with the use of statin medications, there is an associated risk for rhabdomyolysis. So if they're having muscle pain, you might want to have that looked at. And again, it's kind of hard to differentiate intermittent claudication from muscle pain, so we'll have to look further at their labs to see if we have any changes in kidney function. Therapeutic procedures are, again, pretty similar to what we would do for the heart. Obviously, we can go through and we can revascularize that area. We can remove some of the plaque. If it's a clot that is causing the occlusion, we can remove the clot, or we can totally go around that area of occlusion if it's too hard, if the plaque is too thick to get through. So it's a percutaneous transluminal angioplasty and laser-assisted angioplasty. And again, we see the word plasty, so we know that we're doing something to change what's going on. The arterial revascularization surgery, again, we're taking a donor graft and we're just going around that area of occlusion. So I really like these, the use of ARTS and just how these break it out for you. It's obviously, if you have an absent pulse, it's a priority. If you've got red sores, it's a late sign and symptom, again, because we know that's stage 4. We kind of expect toe and feet pain, but again, it should be resolved within 10 minutes, and it's reproducible. If it doesn't go away, then it's acute arterial occlusion. And then we know if you do have sudden sharp calf pain, it should not be consistent. So that's your ARTS. Here we kind of talk about the dangling. So this is the positioning that we are talking about. You want to put your feet in a dependent position. So this is the upside down V, where for venous we're going to make an upright V. But they can keep their legs below the level of their heart. So just keeping their legs in this kind of position is okay for a little bit, but eventually you want to come and remind them to put those feet at least somewhat down so that we can promote blood flow. Just because there is a huge risk for ulcers and ulcerations, you want to make sure that they're performing daily skin care, promote smoking cessation, avoid tight clothing. Now, we know that we can have damage to the nervous system in your lower extremities, the nerves down there. You're not going to be able to feel if you are burning yourself and using a heating pad because you have cold feet. Medications, vasodilators, so your ACEs, your ARBs, anything that's going to help with hypertension, you would also expect to see in the use of PAD and PVD, as well as adding in that antiplatelet medication. So this slide alone can tell you a lot about what to do for peripheral arterial disorder. All right, so we're going to look now, we've gone from the chronic to the acute. So as you can probably imagine, the big difference is pain that does not go away. If you can look at that and you can question a client when they come in and they say, hey, I used to have leg pain when I was exercising, whatever, and now that leg pain is just always there, you need to, as a good nurse, you need to be able to say, I need more information, I need further questions, I need the OPQRST, I need to send you out for duplex Doppler, blood flow studies, whatever it may be. So we know acute arterial ischemic disorders are a sudden interruption in arterial blood flow. We know you're going to end up not having a pulse. It can be from a lot of factors. We've talked about embolization, again, and that can come straight from AFib. If that clot leaves the left atrium and through the left ventricle and goes out into circulation, we a lot of time think of clots because we're going to talk about DVTs, deep vein thrombosis, but you can have an embolization or thrombus in your arterial system as well. This other piece here, this venous outflow obstruction, and so there is just basically a difference in how blood is traveling from your arterial system to your venous system, and it's kind of like with your heart. Blood is going to back up if it's not moving correctly, and then that can cause issues because you already have vasoconstriction. It's going to lead to more issues with arterial disorders. And then, of course, if you are in a low flow state, which is just their fancy way of saying you're not perfusing, your blood pressure is low, you got hypotension, you're in shock, whatever it may be. This is our renal clients who have diabetes and CAD, ACS, hypertension, all the good stuff that we talk about with cardiac clients. So here we see an acute change in this client's leg. The right one is okay, and then here we see some very obvious discoloration of that left foot. This can also lead to compartment syndrome type of signs and symptoms, and that's again going back to that issues where you have either blood is not flowing correctly, or you have issues in your venous and arterial system in the way that blood is flowing. You can have a reperfusion injury if we open it up, just like we say when we talk about when we have an MI, if you open up the coronary arteries, they can go into a dysrhythmia. Well, obviously your feet can't do dysrhythmias. So what we do is we end up with a reperfusion injury because of the increase in blood flow will lead to compartment syndrome. Remember, compartment syndrome is just simply you have something that is backing up, and it's putting more and more pressure on everything inside your lower extremity, and it's going to eventually put so much pressure that you're going to end up with necrosis or dead tissue. You're going to have damages to that muscle, so you can have issues with your potassium. You can end up in metabolic disorders because of that potassium and your hydrogen ions. That will lead you into usually metabolic acidosis. And then with the release of the myoglobin, we didn't talk about myoglobin too much with heart attacks, so CAD, ACS. But if it does break down, it's going to end up as a big protein molecule in your kidneys, and it's going to result in AKI. So kind of like rhabdomyolysis. So we know early treatment is essential. We want to catch them in stage 1 before stage 4. I think that's obvious. If they come in with an acute arterial ischemic disorder, I could expect heparin. I could expect TPA, streptokinase, apixaban, dabigatran. You can do a mechanical thrombolectomy, an embolectomy, surgical revascularization, or worst case scenario, amputation. So this picture does a really good illustration of lack of blood flow to the lower extremity. We don't know why. All I do know for sure is that when I look at this client, I know that that right leg is not perfusing. There is a definite impediment in blood flow where the red arrow is. And then now you can see coming back, we've reevaluated, was that intervention successful? And oh my gosh, yes, we are perfusing like crazy. And probably what you're looking at now is at some point along the way, he's probably going to need that left leg done as well. Again, the teaching does not change. Foot care, avoid prolonged standing, sitting, crossed legs. Teach them about pain, teach them about pallor, paresthesia, absent pulses, so that's part of that good foot care. No restrictive clothing, don't smoke. Again, check your pulses. So we want them to be able to improve in their ADLs. And, we say an increase in exercise tolerance, but NCLEX is going to say clients should be able to participate in their ADLs. You want to have a normal, or for them, a normal peripheral pulse, so either, hopefully, a dorsalis pevius and posterior tibia. And then we want them to be able to maintain that limb at a good temperature and good color. Thromboangiitis obliterans, Buerger's disease. I don't really expect this to be on NCLEX. It's not a high number kind of. A lot of our clients are coming in with Buerger's disease. What I would want you to know is this is a vaso-occlusive disorder. It happens mostly in men. It's usually because of smoking. It does happen, it seems, more in Eastern and Asian populations. So with this client, we do see that she has some cyanosis to her distal extremities. And it looks like that if we don't do something immediately, they would probably be at increased risk for amputation. I have seen, thrombosis. We can give all the clopidogrel and the aspirins and the vasodilators that you want, but I have treated this one time in my life with a client, and what we ended up doing was rubbing like nitro paste on their hands to promote vasodilation. Usually this vaso-occlusion is because of something that is blocking blood flow. Here we say an inflammatory process, so vasculitis, arteriitis. It's closing off blood flow to your hands usually. We want to control the symptoms. It's going to be the same teaching, the same education. Much like Raynaud's. So Raynaud's phenomenon, we're going to say, is more associated with women. And instead of it being a vaso-occlusive, so instead of it being chest pain, it's a vasospastic disorder. So now it is variant angina. And that's how we differentiate them in our brain. Vaso-occlusive, vasospastic. You can see the signs and symptoms are pretty much the same. So you can have changes in color, changes in temperature. We don't really know why that our clients end up with Raynaud's, but we do know that it is generally an exaggerated response of the sympathetic nervous system. Avoid cold temperatures, avoid caffeine, avoid nicotine, and if you learn how to avoid stress, please let me know. I'd love that answer. We do expect that we could use sustained release calcium channel blockers, and in this particular instance, we're going to say specifically nifedipine. So these are our first line drug therapies for our vasospastic and our vaso-occlusive disorders. It's just like we talked about with variant angina. Instead of nicardipine, we're using nifedipine. So patient teaching, client-centered care, all the same. Avoid tight clothes, so loose clothes, warm clothes, avoid the cold. Don't immerse your hands in cold water. Avoid smoking, reduce caffeine, all the good stuff. So that is it for that portion of our lecture. We're at almost the 30-minute mark, so I'm going to record a separate video for aneurysms when we get to there. But remember, we're still talking about the arterial system. So just as a recap with PAD, what we're really concerned about are those signs and symptoms when peripheral arterial disease has progressed. So watch for pain, pain specifically that does not go away. You're going to do the same nursing interventions for PAD that you would do for any other heart condition. So we could expect vasodilators, we would expect antiplatelet medications. If it's an emergent situation, we're going to put them on heparin. You can do clot busters, revascularization, everything that we talked about with coronary arteries, except we're talking about the peripheral arteries.